Hello, everyone. Thank you for being here on this fine Saturday afternoon at the end of this conference. My name is Asya Ofshteyn. I'm a PGY3 general surgery resident at Mount Sinai Hospital, and I'm currently a research resident at University Hospital's Cleveland Medical Center. Today I'll be talking about robotic proctectomy and the disparities associated with the robotic approach. Similar to many new technologies, advances in the past, robotic surgery has been positioned as the next frontier of surgical innovation. It's frequently advertised as such to patients and surgeons in hospitals, citing advantages such as improved ergonomics, 3D visualization, and articulating arms that allow for better dexterity. And robotic systems are purchased by hospitals in part in an effort to improve care quality, attract patients, and improve revenue streams. Robotic surgery is seen as an important improvement in surgical technique, but access to it has been associated with disparities in other surgical subspecialties. For example, in urologic surgeries, access to robotic prostatectomy is disproportionately associated with race and ethnicity, income, and insurance status. Similarly, in gynecologic surgery, robotic hysterectomy is less likely to be performed in Black women compared to white, lower income women, and women covered by Medicaid. Many patients at all stages of cancer care are affected by socioeconomic and racial disparities, and this is true for rectal cancer as well. A recent study by Turner et al. Demonstrated that disparities in MIS rectal cancer resection is associated with insurance status, but not race. We wondered whether robotic rectal cancer surgery mimics these trends in disparate access. MIS approaches are commonly used for rectal cancer resection, but currently there is concern that oncologic outcomes after MIS rectal cancer resection may be inferior to open surgery. Recent large multi-center SET trials failed to show non-inferiority of laparoscopic proctectomy compared to open surgery for rectal cancer, with 2-year follow-up updates coming out just this month in Annals of Surgery, and showing that there's still no clear evidence that laparoscopic approach is equivalent to open. In light of this ongoing debate, MIS approaches for rectal cancer have not been fully universally accepted. And importantly, there's no prospective randomized controlled trial data comparing robotic proctectomy to open surgery for rectal cancer. Whether or not robotic surgery provides an advantage, it continues to be an increasingly popular approach, and our aim was to evaluate whether or not disparities that exist in rectal cancer extend to robotic rectal cancer surgery. We hypothesized that both racial and economic disparities in robotic proctectomy exist. This study was conducted using the National Cancer Database, similar to the prior study that we just heard about, the NCDB. We looked at patients who were 18 years or older with stage 1, 2, and 3 rectal adenocarcinoma who underwent a proctectomy between the years of 2010 and 2014. The total number of records in the rectal cancer NCDB is almost 250,000. We excluded cases other than proctectomy, stage 4 and in situ tumors, cancers other than adenocarcinoma, records lacking operative approach documentation, and other records with incomplete data. So ultimately, we included just over 33,000 records, of which 11% were robotic and 89% were non-robotic. So who receives robotic proctectomy in the US for rectal cancer? On our univariate analysis, patients who received robotic proctectomy were white, male, younger than 50 years old, with stage 3 cancer and with private insurance. There we go. They live in metropolitan areas. They're not close to the hospital that they choose to go to, and in areas with high levels of education and income. The hospitals they choose are academic and high-volume hospitals, and all of our univariate analyses here were with a p-value of less than 0.011. On multivariate analysis, the significant factors that remained associated with higher rates of receiving robotic surgery were male sex, white compared to Black race, private insurance compared to other types of insurance, and stage 3 compared to stage 1 cancer. What about zip code factors? Patients who lived in highly educated areas further than 25 miles away from the hospital and in a metropolitan area also remain significantly associated with receiving robotic surgery. And lastly, on our adjusted analysis, the hospital factors that remained were receiving robotic proctectomy at an academic and high-volume hospitals. So in conclusion, robotic surgery is performed rarely. Access to it is limited for patients who are female, non-white, not privately insured, and who live in less populated areas with lower levels of education and who are unable to travel to high-volume teaching institutions. Further studies in robotic surgery outcomes may be skewed by disparate access, which may limit generalizability. The question of whether MIS approaches in rectal cancer are equivalent to open surgery still remains unanswered, and oncologic outcomes of robotic surgery have not been prospectively evaluated in a randomized controlled trial against open surgery. If robotic proctectomy is found to be oncologically equivalent or better than open surgery, then advantages of robotic surgery may not be accessible to all. And if we don't include all people in our studies, how do we truly know what the benefits may be for all populations? We must make sure that access to new technologies and research that defines them includes all patients. Thank you.